Thank you, Todd, and thank you, Broderick. That was amazing. And thank you to all the conference organizers and sponsors today, and everyone here in the Zoom room. We're really excited to see everyone here. So as Todd mentioned, my name is Stacy Farr. I'm a research assistant professor at UMKC in the School of Medicine, and I'm one of the leadership team of the Kansas City Quality and Value Innovation Consortium, or the KVIC, alongside Drs. John Spertus and Dr. Carol Decker, with whom I've had the tremendous pleasure of working with. And I'm really delighted to kind of share an overview with you all today of what the Kansas City Quality and Value Innovation Consortium is. And we're very excited to partner with the Heartland Conference on Health Equity and on Patient-Centered Care, and also with the Humana Community Conversations Planning Committee to make today a reality. This is really exciting to see everyone here. It really goes to show how vitally important the social determinants of health are when all of these multi-stakeholder groups, when everyone here in the room today from all of your different backgrounds can come together and really focus on how do we make an impact on this for our region. So thank you. And I really do look forward to making some, turning a lot of these conversations that happen today into some meaningful action for our community and change. So thank you. I guess I also have to admit people in the room, sorry. Okay, so first I wanted to give you a little bit of background. So we all know that our current healthcare system is unsustainable as it currently is. Fee-for-service in our country is not working well to deliver health and health care at a reasonable cost. The United States, we spend roughly 18% of our GDP on healthcare, which is significantly more than any other OECD country. And yet with all of that spending, our health outcomes and our quality of care are actually far below other OECD countries and many low-income countries as well. Of all of the OECD countries, the US has the lowest life expectancy, the highest suicide rate, the highest chronic disease burden, the highest rates of avoidable deaths, the highest rates of overweight and obesity, highest rates of infant mortality, and so on. And we know that these are often very worse. And we see a lot of health disparities in these same outcomes across the population. And it's really critical that we actively find ways to do better with less resources. So what we really want to do is kind of focus on the triple aim in Kansas City. We have to start thinking about ways that we can provide better healthcare and better care at lower costs, and to achieve better health and better health outcomes for patients and for populations. And to share with you, kind of as we make this shift from moving from value-based healthcare from fee-for-service, we really need to focus on learning health systems. Sorry, I keep having to admit, okay.
Stacy, just so you know, you don't need to admit folks.
Oh, okay. Sorry, I was like, it keeps popping up, admit people into the room, and I'm feeling like, oh no, they need in. Okay, sorry about that. Okay, thank you. Good to know. All right, so as we make this shift to value-based care, learning health systems become really increasingly important, where kind of looking at the top right of the screen here, where providers can pair with researchers, with community, to use evidence that we have from the literature to inform and work with others in this kind of knowledge network to really inform how we deliver patient care, how we conduct quality improvement projects, how then we can improve and measure health outcomes, and then develop new best practices that we can scale up. And learning health systems and a lot of QI work is currently working within hospitals, but we have to think bigger. We have to do better. So we have to start thinking about how we can move these learning health systems across multiple hospitals working together, and then how we can move that into communities. And we need to start engaging a lot more of the stakeholders outside of the healthcare system, because that's where our problems really often lie. So we need to start engaging more academic researchers, the payers, philanthropy, patients, community-based organizations, so everyone here in the room today, so that we can start making a large impact on patient and population health outcomes, so we can reduce healthcare costs, and then we can also start to reduce more of the health inequities. Community efforts are really critical, as many of our biggest healthcare problems and priorities fall within the social determinants of health. So things about access to quality care, food insecurity, transportation, income, housing, and we're only going to make an impact on outcomes if we can really focus on the larger communities in which we live. And so that brings us to the building of the Kansas City Quality and Value Innovation Consortium. This was started in 2018. And our vision is really to bring multiple stakeholders together to improve the quality and value of healthcare. And we work with, right now our partners are BioNexus KC, UMKC, and the Frontiers Clinical and Translational Science Institute. And to kind of share with you what we've done to date. So the KQCVIC activities to date have centered kind of on these 3 different activities that all inform each other. So first, we held interviews with all of the healthcare stakeholders to identify their most important priorities so we could be responsive to needs and add value to helping them achieve their goals. And through a systematic process, we had a list of 32 different quality improvement projects that were really important for our region. And we narrowed that down to 2 different regional quality improvement projects that we wanted to implement across multiple Kansas City hospitals so we could impact population health outcomes. And so these include opioid management through the program, the Engaging Patients in Care Coordination, or KCEPIC. And we're working currently with 8 regional hospitals on that project. And then additionally, our second project that kind of bubbled to the top was the Transitions of Care for Heart Failure. And this has a focus on the social determinants of health and working outside of the hospital walls, as you can see, where individuals are also living at home and need access to all of the, to food, to meals, to transportation, to their appointments, for medication reconciliation, et cetera. And we're working with 12 hospitals there. And we're also engaging researchers from multiple institutions to help to implement these projects, to measure the success of the implementation, and conduct mixed methods evaluations on the health and cost outcomes of those. And then, kind of working with that in order to ensure that the researchers, the providers, and all the other stakeholders are able to use the best practices and implement them, implement those evidence-based interventions within and across the hospitals. We created a curriculum. So if you move kind of to the right side where it says training, this curriculum is called TIARA, which is Training and Implementation Actionable Research Approaches. And TIARA is modeled after the literature on competencies that are important for implementation scientists to learn, as well as off of other implementation science training programs around the US, such as the NIH's. And this was taught and led by a true visionary leader in the field of implementation science, Dr. Ann Sales at the University of Michigan. We had over 120 individuals attend these sessions, and they learned really important lessons about theory, design and analysis, and some pragmatic considerations in bringing evidence-based practices to hospitals and to our communities. And the third kind of leg is in working on community engagement and dissemination of our findings. And so one of these avenues is our primary one right now is the KQCVIC Forum. And this is where we bring important health and healthcare topics to the community stage to hear from multiple stakeholders and their perspectives on different issues. So we hear from payers, from providers, from patients, from community-based organizations, from researchers. And then we allow time for discussion and collaboration so that we can kind of move some of these projects forward and get collaborations built in the community. And it really does build more of a culture of collaboration and moving outside of individual silos. And, we've kind of brought this model, to part of today's conference, and we're really excited to be a part of this. So thank you. And as you can see, so these activities that we've been working on, they all, work together synergistically to create an ecosystem of improving the value of healthcare in Kansas City. And then to share, this is, so in terms of the KQCVIC Forum, our community stage where we talk about these issues. This was our 2020 schedule, just so you know what occurred, and then also what is coming up. And these are all on our website, the recordings from the past ones, if you want to visit them. And as you can see, today we're partnering with the Heartland Conference on Health Equity and the community conversations for our forum. And so next month is mental health. So just wanted to share that, and we'll be sharing our 2021 schedule very soon. And that's all I have. So I just want to thank you and say that if you want to learn more about us or join us or get on our mailing lists or anything, our website is there and you can sign up. And we really look forward to working with you all and engaging with you. So thank you so much.
Thank you, Dr. Farr. We appreciate your partnership and your opportunity to be a part of this Health Equity Conference. And okay, now we're going to get started with our speakers. We're 3 minutes up in front of time. I love it. I was really concerned about how this virtual thing would go with timing, and so far so good. So here's what's going to happen, folks. We're going to have 2 speakers talk for about 15 minutes apiece. And then we're going to break out into those small groups again and have a discussion about what you just heard or share another story. I'll post some bonus questions that you can, that we'll talk about in the chat box. So you'll be able to have some facilitated, some guided discussion, but feel free to use that time as you see fit. If you want to ask about someone's credentials or someone's work in their community or their clinic or their office, that's all above board. If you want to share a story that you have about health equity in the region, or you have a question about a speaker that just came up that you want some clarification on, or if you wanted to say, let's develop a question. One of the things that we're going to ask you to do is develop a consensus question in your group, and that's a suggested work item. You're not obligated to do that, but that's one of the things we want you to do. So we're going to start with these first 2 speakers. And if feel free to throw anything you want in the chat box if you have a question about to the speaker. We'll gather. We have some folks monitoring the chat box. We'll gather those questions, and then during a Q&A at the very end, we'll spit those back out to the panelists or to the presenters. So just have fun with this. Just relax and enjoy the presentations. And as things pop up to you, please feel free to take them to your group. All right. Okay, well, we're going to start with Dr. Jeffrey Colvin. He's the Director of Research for General Academic Pediatrics at Children's Mercy, Kansas City. Dr. Colvin? Oh, before you start, Dr. Colvin, we're going to post we're not going to do long introductions. We have an introduction or a bios page that we're going to post in the file. You may have already got that. We're going to post it as well in the chat box. So you'll be able to read his introduction or read his bio if you like. All right, Dr. Colvin, all yours.
All right, let me share my screen. Thank you very much for inviting me to share my perspective as a general pediatrician. I work in Children's Mercy's primary care clinic, which is the largest safety net clinic in the region. The social determinants of health are not only a day-to-day reality, they are a patient-to-patient reality for us. Next slide, please. This is my perspective. In modern pediatrics, there are a lot of children born too early, a lot of children with chronic health conditions like asthma, and a lot of children with obesity and type 2 diabetes that set them up for a life as an adult with heart disease and stroke. Take, for instance, my patient, Aaron. He was born a month and a half early and spent a couple of weeks in the NICU. For modern pediatrics, that's nothing. But it did predispose him to chronic lung conditions, and he began to struggle with asthma as a young child. Next slide, please. But his story of prematurity and asthma is not the full story. He was born into a family with generations of poverty. His mother is a single mother who has had her own struggles. They live together in an apartment with a leaking roof, which is a housing code violation. The leaking roof has led to mold in the apartment, which is making Aaron's asthma worse. The landlord won't fix the leak because the family is behind on rent. Aaron's mother can no longer afford the rent, even though his mother works full-time at a fast food chain. She is still struggling with some payday loans she took out when she made a bad decision when she was younger. She now has to decide between paying the full rent or putting food on the table. The food is not what I tell her is healthy, but to her, any food for her children is better than no food at all. Something has to give. What I know as a physician is that Aaron has an apartment full of mold, which is worsening his health. His weight is creeping up, and the family cannot afford the food it should be eating. Most importantly, his family doesn't seem to have a way out. I also know that when Aaron turns 18, he will no longer be my patient. He will have aged out of pediatrics, and an adult medicine physician will inherit him from me. The health problems I can't fix will get passed along to adult physicians. Next slide, please. The complexities of the social determinants of health are not new for pediatrics. In fact, the social determinants of health are the origins of pediatrics. The fathers of modern pediatrics, Abraham Jacobi and Job Lewis Smith, recreated the pediatric field by focusing on health inequities and the social determinants of health. Abraham Jacobi examined the health of low-income new immigrant children to New York City at the turn of the century. Jacobi himself, though he was a doctor, was a poor immigrant. Job Lewis Smith was the exact opposite. He was from the upper class elite and could trace his roots back to the Mayflower. But like Jacobi, his passion was the poor children of New York City, specifically the shanties of day laborers at what is now Central Park. The social determinants of health is not new to pediatrics. It's at its core. In fact, for today's physicians in training, completing their residency to become pediatricians, child advocacy rotations are a requirement in order to teach pediatric residents how to advocate for low-income children. Next slide, please. What Abraham Jacobi and Job Lewis Smith knew over a century ago is still true today. Lower income children have worse health in this country. They have more chronic health conditions and worse health-related quality of life. It is not a poor versus rich thing. It's a gradient. The lower a family's income, the more likely their child is to have poor health, and the more likely their children will have a chronic health condition. The same is true for child mortality in this country. Although the reduction in child mortality over the past 50 years has been incredible, the disparities between children from the wealthiest and poorest families has remained essentially unchanged. Next slide, please. But how does poverty get under the skin of children? Decades of research have demonstrated how complex it can be. At its most complex, chronically elevated stress, often called toxic stress, results in a neurologic and endocrine response that is persistently in overdrive, resulting in permanent neurological changes and alternation of the child's genes, a phenomenon known as epigenetics. However, as a clinician, this is how I see poverty getting under the skin of my patients. Income that is minimum wage, but not livable. Payday loans and other forms of debt that are modern versions of indentured servitude. Food insecurity, not to mention food deserts. Lack of adult health insurance that not only results in worse health for my patient's parents, but also results in household medical debt, diverting money away from other possibilities, like healthy food for the family. Poverty also gets under the skin through poor housing conditions and homelessness, including doubling up. Struggling schools that are underfunded and not meeting our children's needs. Domestic violence and interpersonal street violence, and of course, racism and discrimination, both systemic and personal. Next slide, please. The science tells us that the social determinants of health my patients bring to the clinic are more important than the care I give them in the clinic. Whereas healthcare only accounts for 10% of an individual's health on average, social circumstances is 15%. Behavioral patterns and environmental exposures, both of which are heavily influenced by social circumstances, are another 45% combined. Next slide. In fact, for that reason, they say that health begins where we live, work, go to school, play, and pray. I agree with that, but I also know that the research evidence shows that health begins even sooner. It's the life course. Research has demonstrated that an individual's adult health is often determined by their health in early childhood. Genes that will determine the child's health as an adult are imprinted by the social context surrounding that child. Perhaps more importantly, researchers have discovered that it is the social context of the mother while she is pregnant, or even before she was pregnant, that will determine her child's health both during childhood and as an adult. For Erin, my patient I told you about earlier, we know that stress during pregnancy is linked to prematurity and that food insecurity in pregnancy is associated with obesity in childhood and heart disease as an adult. The stress of the social determinants of health faced by Erin's mother were increasing his likelihood of adult health disease even before he was born. Next slide, please. This means that the health of my pediatric patients are irrevocably linked to the health and well-being of their mother's health. The health of the obstetrics patient determines the health of my pediatric patient. And when they age out of pediatrics, then they determine the health of an adult provider's patient. The social determinants of health during pregnancy foreshadowed Erin's prematurity and resulting asthma. The social determinants then worsened his predilection to asthma and obesity, and eventually his type 2 diabetes and heart disease as an adult. Next slide, please. The history of Children's Mercy is a history of addressing the social determinants of health. Children's Mercy was founded in 1897 by two physician sisters who are now not allowed to practice in any of the existing Kansas City hospitals because they were women. As a result, they would care for abandoned, malnourished children found in the streets of Kansas City. One hospital would rent them one bed for an abandoned child. Other physicians called that bed the Mercy Bed. The Mercy Bed eventually grew to be Children's Mercy Hospital. Next slide, please. Today, we continue the legacy of the Berry Sisters. Our Center for Community Connections co-locates social services and resources, such as a WIC clinic, to help patients address the social determinants of health. We also have the first medical legal partnership in the region to help our low-income patients with their health-related legal needs, like unlawful poor housing conditions. We have the largest safety net clinic in the region. The Psychosocial Screening Task Force reviews the best evidence for screening patients for the social determinants of health, and then ensures that screening and the response to positive screens is uniform and coordinated across the institution. We have a robust social work presence. Social work gets to the root cause of unmet social needs. For a family living in substandard rental housing, maybe enrollment in additional benefits like utilities assistance or Section 8 housing, or even resources for escaping payday loans may allow the family to move to healthy housing. Next slide, please. There's more than that. Children's Mercy has developed home visiting programs for vulnerable infants. Fresh food summer lunch programs and community gardens help provide healthy options for food insecure families. We have a clinic at Operation Breakthrough, the largest Head Start center in Western Missouri. We have shared these innovations nationally through NIH-funded research published in some of the top research journals in the country. Our successes have led to national leaders in addressing the social determinants of health in the healthcare setting, seeking our advice in advancing this field across the country. Next slide, please. So what is my perspective as a physician? Children's Mercy has been innovating in this area since the Berry sisters picked up their first abandoned child from the streets of Kansas City in 1897. Among children's hospitals in the United States, our approach to addressing the social determinants of health and health equity is among the very best. My perspective, though, is that none of this is even close to being enough. I know that health begins not just where our patients live, work, play, and pray. It also begins over the life course, long before a child is born and continues long after a child transitions to an adult healthcare provider. My perspective is Erin. Children with lifelong medical conditions, unmet social needs, and a trajectory towards poor health as an adult. For Erin, it is only when all healthcare and social service institutions collaborate and coordinate that we can help patients like him and his family meet their full potential. Next slide. So thank you very much for inviting me to share my perspective.
Thank you, Dr. Colvin. We really appreciate your presentation and very thoughtful analysis of what pediatrics, and I didn't know part of that history of Children's Mercy. Thanks for sharing that. That's good to know. So next we'll have Stephanie Franklin, who's the Population Health Strategy Lead in the Office of Population Health with Humana. Stephanie?
Hi, can you all hear me okay?
Yes, we can.
Okay, great. So I'm going to pull up my slides. Thank you all so much for having me here. This is my first opportunity to attend, and this is has been really wonderful. So I'm trying to start the slideshow. Okay, here we go. So first, so I'm Stephanie Franklin. I am in Humana's Office of Population Health, and I don't know how many of those on the phone and cameras are familiar with Humana. We are a national health plan. We insure millions of Americans for Medicare Advantage, Part D prescription drug coverage, Medicaid managed care, commercial, and then we have one of the two TRICARE contracts. So we have members across the United States, and we've been in this business for quite a bit, and I'm actually in Louisville, Kentucky, which is our headquarters. But I want to provide a little context because it is still relatively recent that a health payer would be at a conference like this and would be so and value social determinants of health and health equity so highly. You know, we've been in insurance for, I mean, longer than my lifetime. And it is, as we've evolved towards managed care, value-based care, that has really focused attention on whole health needs and not just focus on a diagnosis code and paying a claim, but really on what are all the factors that are contributing to someone's health. You know, Dr. Colvin just covered them so beautifully. So all these pieces that are physical, mental, and social that really are contributing to health outcomes. So a lot of our evolution at Humana really started in around 2015 when Humana declared a bold goal of improving the health of the communities we serve by 20%. And we started going deep in a few communities, in 7 communities, really focused on community collaboration around population health, forming deep relationships with the public health departments and other payers and health systems, other sectors to identify population health priorities and organize and work together to accomplish these. Today we have 16 communities where we have not only staff on the ground helping lead these efforts, but these communities are also our testing ground for new interventions and efforts around social determinants of health, focus based both on population health and the health of our members in those communities. And we have many partners, that both national and local, to help us achieve this. But some of the things that we learned as we were listening to communities were that, as we all know, it's not just what's happening in clinic that is affecting members' health. It's not affecting population health. It's the social and environmental and political ecosystem that people live in. So that really kind of drew our attention to social determinants of health. I will also add that we measure progress toward our bold goal using a measure of health-related quality of life called Healthy Days. It's developed by the CDC. It's in the briefs. I know many of you are familiar with it. And we like it because it factors in both mental and physical health. And as we looked at our data, it was not just a clinical condition that was driving health outcomes, but it was really, for our members, we saw a huge relationship between quality of life and social needs, like food insecurity and loneliness and social isolation. So we have, since 2015, really invested in understanding the social needs of our members. For instance, this is some data from a large national survey that we conducted of both our Medicare Advantage members and one of the states that we have Medicaid managed care. And while it's not surprising to anyone on the phone that a large number of individuals in these plans have financial strain or food insecurity, but we may not really think of Medicare Advantage members, for instance, as 26% of them having food insecurity, or the fact that we have 50% of Medicaid members who are expressing loneliness and isolation. So a lot of this data and additional research has focused our attention on how do we improve address the social needs of our members in order to improve their health outcomes. You know, in some of these insights, we're really working hard to connect the social need to health outcome. Both, you know, we are still speaking to corporate leaders, and so we need to connect it to how do the number of social needs you have, for instance, impact cost or impact quality compliance. So for instance, this is Medicare Advantage members who have diabetes. And in our survey that conducted pre-COVID, right before COVID, we found that 58% of those members experienced one or more social needs. And we're concerned both in individual social needs, so food insecurity, we know that has a lot of connection to health outcomes, but we're also concerned about the compounding effect of social needs, the fact that it's not just one thing happening, it's a whole ecosystem of social needs that are contributing to one another and exacerbating health conditions. So for diabetic members, as you add each additional social need, you can see in that light green line that their monthly cost goes up. And in the dark green line on the other side, as you add each additional social need, their A1C control decreases. So this is, you know, while we intuitively know that these things are important, we can actually also see it in our clinical and claims data that how these social needs are impacting members' health. Which is why our social determinative health strategy has really evolved from a community kind of nice to have to really the way that we're building a sustainable business model at Humana. And all of that starts with treating social needs as true gaps in care. We need, just like diabetes, we want to understand who is at risk and use analytics and segmentation to identify who's at risk of developing the condition, but also who's at risk of progression and complications. We want to screen members in the clinical setting through care management programs to actually diagnose those with social needs, and then connect them with an intervention to treat those needs, just like we would prescribe a medication for a chronic condition. But in order to accomplish this, there are a lot of moving pieces, and this kind of reminds me of Stacy's a slide a little bit earlier with the concentric circles, but at the core of it first is having a social health infrastructure. We have to know which of our members are experiencing social needs so that we can get them the help that they need. We need community engagement, and that's why our bold goal communities are so important, and that's why we're working with efforts like that in Kansas City to really identify how do we connect the different sectors to be more integrated so that we can address population health needs, whole health needs, and really support the community as opposed and not just supplant it or not just put more burden on an already burdened system. And then policy is really a key focus as well, both in that as a heavily regulated entity in insurance, a lot of what we're able to do for our members is regulated by either CMS or states. And so we need the permission space, the regulatory permission to provide things like food for food insecure diabetic members from CMS. But we also recognize that policy, and Daniel Dawes will talk a lot more about this, about the political determinants of health, but we also recognize that there are so many factors that public policy determines that impacts population health. On the next level, there's a great deal of research in the realm of social determinants of health. What we're still working together with so many partners to build is the evidence base that shows that addressing this social need or social needs impacts health outcomes, and how long it takes, and what is the dose response that's appropriate. Because in order to build these into clinical practice, in order to build them into benefit design, we have to really demonstrate the return on health that they're going to have. So we have a pipeline of pilots that we launch, and hopefully as they show success at key milestones, we're able to scale those and ultimately into either some sort of member benefit or through clinical integration. And it's that clinical integration that is really something that Humana has really evolved how we, what we consider health risks and how we conduct health risk assessments and what sort of referrals that we make. Really ingraining a lot of these practices into how we meet the needs of our members as a managed care organization. And finally, that sustainable business model. So now we have the ability to build some of these non-medical, not primarily medical benefits into, benefit plans for Medicare Advantage members, for Medicaid managed care beneficiaries, obviously, but we really do believe that value-based contracting, value-based care will help really align incentives across the continuum of care to focus on what is going to have the best return on health outcomes, and for many, and to get the resources to those members and those patients who most need them. So we're working with providers to incentivize the screening and documentation and referral for social needs. We're working on integrating social risk stratification so that we can direct attention and resources to those members who have both a social and clinical burden, because we recognize that every patient is different and has different needs, and we should be getting appropriate resources to those who need that. So one example, and I'll pull this one out because it is a program that is active in the Kansas City market. I mentioned loneliness, and there's quite a bit of emerging research now on the impact of loneliness on health outcomes. We know that loneliness increases the risk of dementia and Alzheimer's, increases the risk of premature death, and it is very prevalent in across all populations that we have surveyed, and we know that in the time of COVID-19 social distancing, it has become even more prevalent, unfortunately. So PAPA is one intervention that we tested, and we started off with a small proof of concept pilot, and these are the results from that. PAPA, if you're not familiar, connects Papa Pals, they're college students, to seniors who are in need of companionship or kind of basic assistance with basic house help. And we screened members for loneliness and connected those members with a Papa Pal for 4 months. And what we found was this intervention decreased loneliness substantially and improved health-related quality of life, both mentally and physically mental and physical healthy days. So this is something that we felt really good about its prospects of improving the health of the members that were receiving the intervention. So we've scaled this to additional markets. This is also a good example of how we've kind of pivoted when it comes to COVID-19. This, you know, as everyone is aware, it has, this pandemic has really brought to light inequities in our country and the existing social needs, and has absolutely exacerbated those needs. So like many of our other insurers, we try to pivot to telehealth and tried to alleviate the financial burden of health access by removing cost sharing. But really one thing that what popped up was the social determinants of health. We know that loneliness increased. We were doing kind of proactive outreach to members that we believe to be at high risk of COVID, and the loneliness and access to food were the two things that we kept hearing. We had members calling us and saying, I don't have food. So we had to quickly build a system to get food to people. And that's something that has lasted a lot longer. Those needs have lasted a lot longer than even we could have anticipated. And for programs like PAPA, which was an in-person intervention, we worked with them closely to pivot to virtual visits. They helped the seniors that they were paired with learn to use Zoom and things like that, so that they could talk not only to their Papa Pal, but stay connected to family. We also were able to add sort of grocery shopping and delivery as a service that the Papa Pals could provide. So in part of that time could be used to make sure that those the members that they were paired with could have access to food. In the interest of time, I won't go into all of these, but happy to discuss more. And I don't think I have my email on the end of this, but I'll put it in the chat afterwards for questions and follow-up. But so now we're kind of we are at a crossroads. We have, the current crisis and all the other pieces that were already bubbling up. We really believe that this is going to further the transition to value-based care and outcomes-based care, and we think, and Humana thinks that this will really help everyone better address the whole health needs, including social and mental behavioral health needs as well. We also need to tackle inequities, as you all well know, but we are also on this journey at Humana for a long time. We have been haven't had the ability to offer truly individually tailored benefits to our members, and now with recent changes at CMS through special supplemental benefits for the chronically ill and VBID, we're really able to more directly tackle some of the specific needs of at-risk populations. But I will just emphasize how important it is and how much we value the collaboration of all the different actors and sectors that are represented on this call. We truly value all that you contribute to population health and appreciate your partnership. And I look forward to your question.
Thank you so much, Stephanie.